Hi everyone, I'm Susan Birch, the Health Detective, and welcome to another episode of the podcast. Today I have the multi-talented Dr. Vyvyane Loh with me. She's a medical doctor, she specialises in obesity, but she is also a dancer, an author, a wonderful presenter. She has her own podcast, which I highly recommend that everybody check out. So, Vyvyane, thanks for coming along. I'm super excited to have you here today and share you with my audience.
Thank you. I've been looking forward to it.
Yes, so have I. Shall we start off by you just giving everyone a little bit of your background, and then we can get into our topics for today.
Okay, sure. I am board certified in internal medicine and obesity medicine. And really my focus is on metabolic health. I was very lucky because I burned out very early in my career and really had to look at my own health and how I was not taking care of myself, right? And I realized that, you know, despite all the training that I had, that we really had never learned anything about taking care of ourselves and preventing illness. And because this was early in my career, it really allowed me to think about the path I wanted to go on. And that's been my focus since.
It's quite interesting you say that, because we look at our doctors and we expect that they know everything about how to keep themselves healthy and that they're an example for us. And yet, you know, that's obviously isn't always the case.
Yeah, I think, you know, we're taught to sort of look at the medication use and how to treat patients according to different algorithms and so forth. But there really wasn't in my curriculum anything about preventing illness, anything about reversing illness. And I had to take a cold hard look at myself because I got to the point where I was very burnt out. I was tired. I didn't feel very excited about my job anymore. And I also felt that I wasn't really helping my patients, really. And I needed to figure out first how to take care of myself. So I always tell my patients, I'm not exempt. If I ask my patients to do something, it's something I've done and tried and I'm still working on. And I share that openly with them because I always say, you know, don't ask someone to do something you're not willing to do yourself. So I think when we are working with patients, it's easy to set up this dichotomy of them and us here. And I'm just us, you know, because I've got to learn how to take care of me. And if I learn something along the way, I hope I can pass it on and help you out with that, you know?
I think that's absolutely wonderful, and it brings a whole lot more humanity into the space. And like you say, it becomes a shared journey, doesn't it?
Yes, absolutely.
So you've set up your own practice now?
Yeah, so in the last 7+ years, I've been on my own, and it's mostly realizing that, you know, the healthcare system that I work in is broken, and you really can't build something new from within a broken system. So being outside of that and being on my own allowed me a lot of freedom to practice the way that I thought was appropriate for my patients.
And I think in this sort of metabolic health space and, you know, looking at the insulin resistance and, you know, the contribution of carbohydrates to chronic and processed food to chronic disease, the importance of protein, you've been doing this for quite a substantially longer time than a lot of the sort of stars that we have in this space. You've just been working quietly along in your own space and time doing this. Yeah,
and of course, you know, I like that there are stars out there now because they're inspirational. And, you know, I'm here on my own. I'm a sole practitioner, so it can get pretty lonely. And also in the sort of conventional medical field, it can feel a little bit isolating to be doing this on my own. So it's really nice to see that people are bringing this message to a larger public. And, you know, patients are really hungry for this, because I think people are starting to realize that the system that we've had hasn't worked. And, you know, we can't keep going on like this.
Yeah, I think that's really well said. And I think the stars out there do help highlight the issues that are going on, and they help the rest of us get some traction as well. But hopefully this podcast will make you a star as well.
Well, you know, I think the main thing that I've learned along the way is just how complex our bodies are. And there's not one simplistic answer, right? And, you know, every time I get excited about something, oh, I figured this out. I realize I figured a tiny piece out, and then it's brought on 60 million more questions. And that's kept me really humble. And I've realized that, you know, we have some important pieces now, and we can really start to build on that and work on it together. But we certainly don't have all the answers yet. But I guess that's what keeps me going too, because it's kind of exciting to wake up every day and learn something new.
Yeah, I couldn't agree with you more. I love the learning journey that we have.
Yeah.
So let's start talking about, well, let's start with obesity medicine, metabolic health, and then we'll go from there.
Yeah. So, you know, people think of me as an obesity doctor and therefore a weight loss doctor, which is something unfortunately, that's what brings people to me, but that's really not my focus. I mean, obesity is a metabolic disease. Diabetes is a metabolic disease. Cancer is a metabolic disease, right? And so obesity is part of that spectrum, but it is the most visible. And so, you know, that's the one I think that people focus on. They don't necessarily think of it as having its root cause in, you know, metabolism, for example. So my goal in working with my patients is to get them to understand that their weight is just a symptom. So, you know, you have a high blood pressure, but it could be for many reasons. Maybe you just ran a marathon. Maybe, you know, you've been very stressed, you know, it could be partly something in your diet, or you haven't slept well. And we don't just pick on one thing and say, oh, well, if you have high blood pressure, that must be why. There are a range of things, and we have to sort out all the pieces. And your weight is just a number, but why you're at that number, right, we have to figure out, and it could be very different for different people. So understanding those pieces and trying to figure out what works for each individual, I think, is really important.
So can you describe or explain metabolism a little bit for the listeners? You know, what do we mean? You know, we bandy this word metabolism around, but what do we actually mean when we say that?
Well, I always talk about metabolism as the regulation of the flow of energy in your body, the management of this energy and the resources in your body. To do anything, you need energy, right? For your immune cells to do anything, they're going to need energy. For your kidney cells to do anything, they're going to need energy. For your heart cells to do anything, they're going to need energy. And we have we're, you know, multicellular and very complex. We have different organ systems, and the body has to parcel out and regulate energy in these different organ systems depending on different priorities. Now, it's not as if, you know, only one metabolic process is happening at one time in the body. Generally, we have several of these processes going on in different organ systems, and there's a net balance depending on the tissue you're looking at, right? But the body has to make these very complex decisions because, you know, if we prioritize energy to one part of the body, let's say for healing, if you had a cut or you had an incision that needs to be healed, that means we're taking away that energy from some other part of the body, right? And that's not without consequence for that body part, those other body parts. So these decisions are being made all the time. We're not aware of it, obviously, because your body is really good at doing that. But if we upset the system, or we're in a chronic duration of imbalance within your body, then things start to go awry. And that's when we start to have the onset of disease.
Yeah. And we get the symptoms of those diseases first, and then, and then the disease progresses. I love that you're talking about energy in that way, because I talk about energy all the time as well. And that, our cells have to make energy to do their work. And if they can't make that energy to do their work, then that metabolic decline happens. And
Yes.
I was hoping to get into this topic a little bit later on, but it might be worth touching on a little bit now, is that, we are always looking at what I call sort of the calorie aspect of our food. So we're always concentrating on, what proportion of carbs and proteins and fats we should use. I do tend to think of proteins as being a nutrient aspect, but nutrient density, I think you focus a lot on nutrient density. We need the amino acids, we need the vitamins, we need the minerals to make so the metabolism can do its job and work and make energy and recover from the work that it's doing, so it can clear the exhaust of making energy.
Yes, you're absolutely right, Susan. I think we focus so much on the calorie aspects of food and energy. And actually, I'm more really looking at, the cellular level, and also at the flow of electrons, right? And the energy carriers and the currency of energies that we have in our bodies. And those are not so easily accounted for. When we think of calories, we have this general sense that, oh, you burn so much, you eat so much, you burn so much. But at any point in time, there's a flow of energy, and we are electrical systems. And it's hard to account for that type of energy, and also the nutrient flow, because you need, for example, certain nutrients for you to carry out certain biochemical processes. If you don't have those nutrients, then everything can grind to a halt, for example. So, we think of energy very simplistically in terms of calories and so forth, but it's really way deeper than that. And I think that's the part that we're missing when we talk about energy regulation.
Yeah, I couldn't agree with you more. That's thanks for that. So let's talk a little bit about how you help your patients and what you do, and what would be a process that your patients go through with you.
So we actually see our patients in classes, and generally our flagship program, we have a 12-week class, and the patients attend these classes. There's a very strong educational component. So I teach the medical side for an hour, and then I also teach exercise for half hour. And then after that, we have an hour and a half of behavioral, sort of classes. So in the behavioral side, they learn about meditation, but also we use CBT-based techniques, for example, to examine our thinking and to process, some of the reasons that people eat, because there's physiologic hunger and then there are other types of hunger as well, right? So, these patients go through a pretty involved, I would say, class structure. And at the same time, they have homework. We follow them quite closely. And throughout the 12 weeks, we're trying to help them reset some of their habits, and also change some of their sort of regular patterns around eating, for example. I'm very big on circadian rhythm. So getting them to eat at structured times, planning out the time, planning out the amount of protein per meal, right? So we take them through those classes. Beyond that, we have a phase that we call balance, where we help to keep our patients in that metabolic balance. So I just talked to a patient today, and he has lost a huge amount of weight, almost 200 pounds, but he's going on to have surgery for a hernia. And, you know, we're planning how we're going to help him through the surgery, because metabolically, we don't want him to lose muscle mass, right? We want him to have enough energy and nutrients to heal properly. So, you know, for his surgeries in December, but we already, once we had the surgical date, we already started planning around that, right? So we try to work with each patient depending on what phase of life they're in and what they might be encountering, so that, you know, we can try to make sure that they get through each phase in the best possible shape.
So let's talk a little bit about body composition then, because I know that's something you're very big on. You know, we've got sort of skinny fat, we've got, you know, this TOFI, we have this focus on how much do we weigh on the scales rather than what's the quality of our weight.
Yeah. And, you know, unfortunately, everybody's going by BMI these days, and they're going by that number on the scale. It's hard to convince patients, and so it's unfortunately also hard to sometimes convince practitioners that just focusing on the number is not going to be very helpful and may work against the patient. Because I really want to try to, especially as we're aging, prioritize the muscle mass in patients, make sure that they don't continue to lose muscle, because metabolically muscle is really active and will help you manage your glucose, for example, right? It's a nice sink for glucose. And what people don't realize is you can be eating the same things, you could keep the same diet, and you're fairly active. But if you start to shrink that muscle pool, then you have a smaller sink for the glucose to go into. And over time, we're going to see a rise in those glucose levels, right? It's hard to get people to focus on that and to prioritize, you know, keeping muscle on. And it's not so easy to build muscle, especially after a certain age. So really having people focus on that is hard. And then because everyone's so focused on losing weight, right, then what I tend to see is a restrictive pattern. People will restrict food. Okay, and now I'm like, well, I don't think that's helpful in the long term for muscle, because we do need a certain amount of protein. And that's where I think we need to be a little bit more nuanced about, you know, our dietary recommendations. And I think we should also have the understanding that for short term, certain types of, you know, dietary manipulations may be helpful, but certainly you may not want people to live there, for example. Okay, one example I would give is intermittent fasting. Okay, now I have found it helpful, certainly, and there are some patients in whom I will use that on. It's a tool. Okay, but to have someone live there, especially as they're aging, right? I mean, we're missing out on many pieces. If you talk to anyone, I ask you to just approach anyone who's done intermittent fasting and ask them what time the first meal is. I will bet you it's noon or afternoon. Most people who do intermittent fasting, they skip the morning meal, okay? And they start eating around noon or afternoon. Now, if you think that you've not been eating overnight, okay, and that's a huge catabolic window, about 5 hours into your sleep from, 5 hours from the last meal, we start to go into a catabolic pattern. And if you are aging, right, that can be accelerated. So now we've gone, let's say 10, 12 hours, but we're going to wait another 5 hours before our first meal. So that catabolic window has already extended. Secondly, you've shifted your circadian clock in terms of eating. And I think there were recent studies, that you should be eating according to your circadian rhythms, blah, blah, blah. We've known that for a long time. But, if you're now offsetting your circadian clock, you're eating later, you have a longer catabolic window, there are a lot of disadvantages there. And whatever advantage the intermittent fasting may bring, you might have lost some of it, right? With some of these other issues that we're setting up. Also, it's very hard to get people to have enough protein and dose it correctly per meal if they're also doing intermittent fasting. Very hard to get the protein in. So we're not really going to be preserving that muscle mass. And you can't just have a big protein meal because your body's going to handle that very differently, right? I mean, protein can also be converted to glucose, and sometimes people don't realize that. So, and you can get an insulin response from that, right? So we really have to look at the big picture and not just focus on one aspect. So while something like intermittent fasting can be helpful, can be a good tool, it's not something I tend to keep a patient on forever. And most people will tell you it worked for a while and then it flattens out for them.
I'm really glad you raised that point, because I've had concerns about not just intermittent fasting, but some of these multi-day fasts as well. And I feel in this space that we're all in, like Dr. Jason Fung has used, he's kind of the fasting expert. And I think there's, probably a lot of mechanisms why that works so well. He works with very obese populations, but then we just automatically assume that that's going to work for everybody. And I get quite concerned with the kind of CrossFit, healthy, carnivore or keto group who then are trying to fast for, 4 or 5 days.
That's right.
That's right. And they say they feel amazing, which of course we can explain by kind of the neuro changes that are going on and the elevated cortisol. But what it's doing to their body composition and mechanistically to, all the other systems in their body does concern me.
Yes, absolutely. Like I said, you can use these strategies short term for a specific process, for a specific purpose, but to do it indefinitely. And I do know lots of people who just basically go about with 1 or 2 meals a day, and then you realize that they may have significant nutrient deficiencies as well. So, it's really hard to kind of make sure that we get everything in and look at different aspects of eating and not just focus on one.
And then, there's this tendency, that we all have possibly to, sort of swallow some supplements as a insurance policy against the nutrient deficiencies. But really, we're wanting nutrients from food, aren't we?
Yeah, as much as possible. I mean, I'm in the US, and it's a little hard to persuade people that a lot of the processed stuff isn't food sometimes, right? And people will always say to me, but you need to eat food. And that's what I'm like, okay, yeah, but those are chemicals. You don't need those. And it often takes them by surprise. The other thing is also that we have a lot of nutrient deficiencies now in our soil, for example. So even our food supply, it really depends on the population that you're dealing with too. If you have someone that can, consistently either grow their own food or get very high quality food, right? That's one situation. And then you have people who maybe don't have those similar circumstances. And then at some point, I think about it and I may supplement. A big one for me, for example, is vitamin D, because living where I live, there's just so much D deficiency. And, especially in the winter months, but even in the summer months up here in Boston, you're not going to significantly get enough of the UVB lights to get, your own vitamin D. So, in some of those patients, yeah, I supplement, especially my patients also, people of color, vitamin D deficiency very high, and that significantly impacts your health, your immune system. So those things, I may ask for supplementation, but I'm also wary because sometimes people will just, figure out, oh, well, if we need more of X, then I can just take supplements, and you may be causing more harm than good, right? Because again, it's always a domino effect. It's not just one thing, you supplement with one thing, but it's impacting so many other pathways, and it's hard to keep everything in mind.
Yeah, and that's why I think it's so important to, be testing. Vitamin D is a classic example because vitamin D and vitamin A compete for the same receptors.
Yes.
So if people go out and just start supplementing vitamin D, thinking it's healthy and safe and it's going to improve their immune function, they run the risk of vitamin A deficiency, which is equally as important for our health. So I think,
yeah, the A receptor is actually heterodimerized to the D receptor, and when A is bound, retinoic acid is bound to that receptor, it actually changes conformation. So it almost points the vitamin D to where it should bind. It almost sets it up for vitamin D to bind optimally and says, here is the binding site, right? So you get optimal binding when you have the A bound, and then the D automatically knows where to go. So, supplementing, you have to make sure that you supplement not just the actual vitamin, but whatever it works with and in a bioavailable form, as you pointed out. Otherwise, and that's what frustrates me, and I'm sure you as well, about studies where I threw a drop or a speck of vitamin D at someone. Oh, it didn't work. Oh, D doesn't work. And I'm like, well, first you need to know how it works.
Yeah.
Right. Yeah. And then supplement properly. So a lot of those studies are very frustrating because you just feel like that's good money down the drain.
Well, I think a lot of the studies show that these deficiencies appear in unhealthy populations. D is a classic example. And then they go on to say, but when we supplement with D, like you said, it doesn't work. And that's because, supplemental D is slightly different than the D that we convert from the sun in our skin, and it's slightly different than the D that we get from our food.
Yeah.
And then, like you say, we've got to have vitamin A to come alongside it and a whole lot of other interactions. So I see that with the B vitamins, and you look at homocysteine, and then they say, well, elevated homocysteine will be, B12 or something deficiency, but supplementing with B12 doesn't improve homocysteine. And it's almost like they haven't got the whole process, understood the whole process, and what else do you need with it? And again, you're going to need vitamin A to be able to absorb and use vitamin B properly. So
that's right. And, this is what's missing in the medical school curriculum, right? In nutrition school and in medical school, if they even teach nutrition, it's down to something very simplistic and, almost embarrassing, the level at which they teach it, when it really could be something that, can engage the students and really, start to have us have meaningful conversations around real nutrition. But that's still not happening here. I'm not sure about in New Zealand, but certainly not here.
I think it's probably worse in New Zealand, but anyway. Anyway, we do what we can to solve the problem.
Yeah.
Let's talk a little bit about, I'm sure everyone's hanging on the edges of these seats, waiting to hear, what's your, I don't like saying nutritional philosophy, but, do you have a style or a way of eating that you recommend? We're talking a lot about protein. What else is included with that?
Well, protein, healthy fats, and then some vegetables. I'm torn a little bit about the fiber, because the studies around fiber, they're kind of mixed and it's hard to sort out. But for the most part, my patients do a lot of the insoluble fibers, so the green leafies, and there at least we have some of the mineral contents as well, some phytonutrients as well. So they're mostly prioritizing protein. They know to prioritize the protein and healthy fats, and then vegetables, and then how they divide out the meals. Most of my patients are eating about 4 to 5 times a day, every 3 to 3.5 hours apart, because as I said, I try not to get them into a catabolic window. And then, overnight, there's not much you can do because you're sleeping. Plus, I think it's a good idea to have a period where you're actually not eating. And, the primary circadian clock is your SCN, but really the secondary one, the one that's also very important that people miss, would be your GI tract and the timing of your meals. So setting your circadian rhythm by timing of meals is very, very important as well. So keeping those windows where it's daytime, nighttime, that's really important to me, in helping people stay in good metabolic health. So that's a big part. The circadian rhythm, I think, also gets ignored, in terms of meal timing, in terms of exercise and activity. I really, really try to respect the light-dark cycles.
Mm. And so what do you suggest about exercise activity with light-dark cycles?
Obviously during the day. Now, it really depends on people's schedules, but personally, I work out in the morning, and I do have patients who they work out after work and so forth. But obviously, I don't want them to be working out too close to bedtime, because that might interfere with sleep and so forth. And then it's how you get your meals in and things like that. So we have to work with each patient individually. I certainly have a lot of people who do shift work as well. And a lot of doctors doing ER shifts, or, I have respiratory therapists, for example, who work in the hospital and they're doing overnight shifts. So really helping them figure things out. And I always go, look, we can do the best we can. At some point, though, you're going to have to get rid of the night shift. And my feeling about that is you pay your dues, you do the best you can, but beyond a certain age, you really have to try to shift back to a day schedule. Otherwise, there's just not a whole lot we can do to, optimize the metabolic health there.
Mm.
So the shift workers are the ones I worry about the most.
Yeah. And, they're stuck between a rock and a hard place, aren't they?
Absolutely, absolutely. And figuring out also what's really hard is when they come off and they have rotating shifts, then the meal times are always changing, and that's a nightmare to try to manage.
Yeah. Well, let's talk a little bit about inflammation. I know you have a wonderful YouTube video out there about the macrophages, which
Oh, bless you for mentioning that. I love macrophages.
I know. It's very enlightening. And so I'd like to talk, a little bit about inflammation, a little bit about macrophages. And, in the beginning, you were talking about, you have a very big overview of your program. It's about nutrition, it's about exercise, it's about sleep. And it's also about mental health and, our neurophysiology and our ability to rewire our brain. So I'd like to talk a little bit about inflammation and how inflammation affects how we think and depression and things like that.
Yeah, absolutely. So, for the longest time, I think people focused on sort of the adaptive part of the immune system. It's very complex, the B cells, the T cells, and, the making of antibodies with B cells and so forth. And I think the focus has been there because of the development of vaccines, for example, and preventive health in that context. And the innate cells were seen as sort of brute cells that just kind of went around chomping on, germs that they found, but they weren't very interesting. Yes, but it turns out, and I have to say, I think that these cells are amazingly sophisticated and complex, right? So the innate system would be your ready-made defense system, so that if you got a cut right now, you have immune cells within your body that can go right to work and protect you from bacteria or viruses that may be, infecting you. So those cells are very complex, and they are also, I think, very much involved in disease initiation, in the initiation of almost all diseases. It's that innate system, very, very powerful. So we traditionally thought of these cells as just non-specific, for example, and that they have no memory. And it turns out that that's not true, because with your macrophages, for example, it has what we call now trained immunity, so that once it's been exposed, on second exposure to another pathogen, it's sort of been revved up and trained to respond in a more aggressive manner, right? And it does so by switching metabolic pathways. So this is fascinating to me. It's a field of immunometabolism, and your immune cells know when to go on the offensive, or they can rev up and go into the offensive when they switch on certain metabolic pathways, and they become quiescent and quiet and go into a resting stage in using different metabolic pathways. So you can actually stimulate cells to go into an aggressive, let's say, rev up your immune system mode by turning on certain metabolic pathways, right? So that's where I think we're starting to see a lot of work being done, certain substrates in the Krebs cycle being more inflammatory, and other substrates kind of promoting a more anti-inflammatory program. And the key is, we're so used to thinking of inflammation as bad, and everybody wants to be anti-inflammatory, but it, like anything else in the body, is the net effect, right? And we have to have both. And if we have too much of the anti-inflammatory programming in your body, basically that's another way of saying you're immunosuppressed, because you can't rev up an immune response. And when you say immunosuppression, people go, oh, that's not good, right? But if you say anti-inflammatory, we assume that's good. But it's always going to be this balance between the two. And I think that those innate cells, particularly the macrophages, are really important in guiding that balance in your body. So that, when we talk about the immune cells in your brain, the microglia, as I mentioned in that talk, they are macrophages, right? There are macrophage populations in pretty much every tissue of your body. And they have very, very sophisticated functions. I mean, in the gut, they could be guiding your epithelial cells as to what is poisonous and what is not poisonous, when to take in water, when not to take in water. They're sending signals to the brain all the time, to help the brain assess what's going on in the gut, right? They help in energy regulation. In your fat cells, they are doing very, very interesting things. I think in that talk, I talked about the mitochondrial transfer that is occurring between fat cells and the macrophages, right? And also how they can block epinephrine from getting to fat cells, right? So they're really at the interface of metabolism and how the different tissues in our body work. So, you know, your immune system, I think I started off this way too, Susan. I started thinking of the immune system as these specific cells, the way they teach it in medical school, right? And I realized that really your entire body is integrated into that, right? Yeah, there isn't a real separation. No, you know, you have special, you know, receptors that we find in red blood cells, for example, and platelets, right? There's a lot of similarity between platelets and macrophages, for example. That's something I didn't highlight in the talk. I mean, if you want to go into macrophages, you could spend hours and days, but you know, there's just this fascination for me of how plate-like macrophages can be, right? And a lot of similarities between the macrophages and platelets, for example. So I still have this fascination for macrophages, and I probably will in the podcast be looking at other aspects of macrophages, and I hope that will be as interesting for other people as well.
I'm sure it will be, and how macrophages assist in our health, and then what we can do to support the macrophages and make sure that they're doing their job properly.
Yeah, I mean, I think that, again, keeping the body in balance, you know, helping to keep the body in balance is the best that we know how to do right now. And that is you know, prioritizing the basics, good nutrition, sleep, right? Mental health, because again, if you think about the brain, it takes up about 20% of your entire energy expenditure, right? And if you're stressed, it goes up as high as 25%. So this is really tissue that's metabolically very, very expensive. Right? And if you think about it, if you have, you know, mental health challenges and problems, that's a huge stress on the body, a metabolic stress on the body. It's consuming a lot of energy, right? And there's a revved up immune response in the brain as well. So, you know, this has to affect the rest of your body. What goes on in the brain doesn't stay in the brain, right?
Yeah.
It affects every part of your body.
And I think of that as also increasing that nutrient burn rate. So, you know, as soon as the stress is ramped up, as soon as your adrenal system is ramped up, our demand for nutrients, our demand for magnesium and copper and iron and you know, all these nutrients that run, you know, that Krebs cycle.
Yes.
You know, get absolutely ramped up. You know, all those B vitamins, vitamin A. You know, we need the whole lot.
Absolutely, absolutely. You know, people prioritize again the macronutrients. You hear the fight is always over the macronutrients, right? No carbs, more carbs. I don't know, but the micronutrients sometimes get ignored. And you don't run the Krebs if you don't have some of those micronutrients, if you don't have the minerals, for example, right? So people, I think we need to start looking at it from a more nuanced point of view, right? And that conversation, I think, has yet to happen on a larger scale. So even when you look at the nutrition studies, right, it's mostly, and I pointed this out a few times, it's just based on what you remember you ate.
Yeah. Yeah.
I don't even remember what I did 10 minutes ago. So, you know, and we're hoping people will accurately report, you know, what they ate. So I remember there was one this study always gets dragged out every few years. We always make fun of it. I have to find it. But it was one that sort of said that that somehow the consumption of eggs is associated with bad health. But if you look at how they kind of assessed the consumption of eggs, basically if you had baked goods, if you had pastry, they had egg in them. So, you know, if you ate them, you had egg, and that was bad for your health. And it's so laughable that, you know, but that gets dragged out every few years.
I think that was one that came out of China or something, wasn't it? Yeah. It got dragged out a couple of years ago, actually. I remember doing a bit of a rant about it.
And I'm just like, seriously? So the pastries and the donuts have nothing to do with it. It's just the eggs in them. Okay. All right. Who would have thought, right?
It's absolutely crazy.
Yeah.
Hey, I'm jumping around a bit with topics here, but I'm just kind of touching on a whole lot of things that I think people would appreciate your point of view on. So I want to talk about hormones, and I want to talk about, you know, the sex hormones for women and for men. And women are, you know, I don't know if it's increased, but there's huge menopausal symptoms being suffered by women, and perimenopausal symptoms being suffered by women. So I'd love to hear your perspective on our baseline nutrition around that. Is that having anything to do with the progression of those symptoms? And even your thoughts, I don't know if you do anything about hormone replacement or bioidentical hormones.
So yes, I think that nutrition has a huge role to play. And the other thing I think that may have a huge role to play is our sort of fascination with putting everyone on earth on statins, right? So that will drop the cholesterol levels to non-existent levels. I mean, I have patients that are getting their cholesterols to 30 or 20, the LDLs to 20 or 30. And I've asked, I've said, and why did they do that? Why did they put you on this medication? The answer so far has been, well, the guy who invented it thought I should be on it. Okay.
Yeah.
I mean, you know.
Yeah.
Okay. Might want a second opinion, because if the guy invented it, I don't know. But so, you know, we seem to think that this is, and I have all these women patients who come to me with non-existent cholesterol, and I'm like, well, I don't know, where are we going with this? I mean, you know, and so I think that too has a huge part. We don't talk about that, but you know, obviously, you know, you're going to have problems with pretty much all your hormones if you have no cholesterol in your body, right? In terms of bioidentical hormones, that's something I do support. I don't actually prescribe them, but I have sent my patients to other doctors who do that. And it's just, you know, for me, I think it's something that, like you mentioned, a lot of women are suffering from symptoms, and they could get a lot of benefit from the hormones. But again, it's very hard to have discussions around topics like that without, you know, people having their own either personal views in there or their own judgments in there. You know what I'm saying? So I think that's what makes it complicated for a lot of patients. But certainly, I think that hormonal replacement is something that we should be talking about and considering in patients. Not everyone needs it. And I'll say, for example, a lot of the men who come to me, if we get them to a point where they lose the visceral fat and we optimize their body composition, many of them end up not needing their testosterone replacement, for example,
Mm.
right? And I certainly have a number of patients and their doctors have sent them saying, listen, okay, we put you on the replacement, but you know, if you get treated properly and you get rid of that visceral fat, you probably won't need any. And that's happened for a few people. So it really depends on the case and the person.
Mm. And I think it's, you know, it's interesting that, you know, especially with menopause, and probably I probably don't work so much with the men around testosterone, but certainly with the woman, it is a Western phenomena, you know. Other, you know, many other non-Western cultures don't have the same symptoms until they start adopting a Western diet and a Western lifestyle.
Yeah.
And so I
Yeah.
always think that's quite important. And I don't know, personally, I think protein, you know, having a good protein intake throughout your life probably helps. I don't know. I mean, I don't know that I've seen evidence of that. I don't know what your thoughts are about that.
I think that that's certainly true for almost everything, Susan. We don't generally consume enough protein. That's been my assessment in my patient population, right? That's not something that is really kind of emphasized. And even when patients get nutritional counseling, right, they generally don't get enough good quality protein, right? And so it's not uncommon for a patient to come and they maybe had one or two doses of protein in the day, and that's not even sufficient enough to have any meaningful protein synthesis going on in their bodies, right? So I think that's a big part of it.
Yeah, and I think there's a real lack of understanding about exactly how much protein you need to eat at a meal. You know, I have people who say, well, I have an egg, you know, and it's like there's just not enough protein.
Yeah.
There's not enough leucine in an egg to stimulate muscle protein synthesis. And
that's, yeah, it's 7 grams. And then the people who have egg whites, well, just take away 2 grams. Now you have 5 grams of protein in the entire meal. And that is pittance. That's not enough to really kind of, like you said, it's not enough of a leucine dose to get your mTOR going, right? So there's no meaningful protein synthesis. And if you are above the age of 40, and you have anabolic resistance, that's going to get harder and harder to get your mTOR started, right? You need a higher protein dose, and you need to have it in that meal. So to your point, Susan, the people who's like, oh, well, I eat protein all through the day. Well, your body needs to see a bolus. It's that bolus of leucine that will, you know, kind of jumpstart the process. And making sure that you have it per meal and dosing it per meal. That's something that we really get into our patients, because you can't just, you know, nibble here and nibble there and then say through the day I got X amount of protein. That's not the same. And that's where we need to, again, get very sophisticated, because how you dose it is going to be very important. Yes, absolutely.
And you've mentioned anabolic resistance a couple of times today. Can you explain to people what you mean when you're talking about anabolic resistance?
So what we know is that, you know, at a whole protein load of, let's say, 20 grams in someone who's maybe in the 20s or early 30s, that's enough to start their mTOR towards protein synthesis, right? And, you know, if you're young, you can get away with a 20-gram meal and get decent muscle protein synthesis. But as you get older, it is much harder to turn on that mTOR switch. And so you will need higher doses of protein. And it's much harder for you not only to jumpstart the process of making protein and making muscle in your body, it's harder for you to keep the muscle as well. So over time, people tend to have more muscle loss. The general idea is like 3 to 8% of muscle loss over a decade. And I actually think it's more than that. It's probably, in my opinion, 5 to 10, 12% over the decade, right? And in certain populations, it's even higher. So if we're not really paying attention, then all of a sudden you might have lost 10%, 15% of your muscle mass over 10 years. And this is just going to progressively get worse, right? It's very hard to keep muscle on and to build muscle as you age. And so you will need higher doses of protein. And in fact, studies have shown that in an elderly population, so let's say 60 and above, giving them a protein meal right at bedtime is helpful, will mitigate some of the catabolic losses because of that long overnight period without eating.
Mm. And I think, it's so important to understand that our body runs on protein. And if we're not eating it, we're breaking down our muscle and our other proteins to supply those amino acids that we need for the body.
Yes. So, yes, muscle is made of protein. Every hormone is protein. Cell signals are protein, right? All the cytokines you make, right? Receptors are proteins, yeah? If you want a gene to be, kind of translated, it's made into a protein.
Yeah.
Right. And that's really the source of life. So you don't have proteins and we're not doing anything. Yeah. So we think only of muscle, but almost all cell processes, your entire cell depends on protein, your entire body depends on protein, signaling, hormones, all of that depends on proteins. So expressing those genes means that those genes are made into proteins, right? And that's one part that we forget. Right? So we do need protein, yes.
And what are your thoughts about mTOR? Because, there's a lot of concern raised now about don't eat protein because it's going to raise your mTOR. But, I've seen research showing that, insulin raises mTOR worse than protein, or for a longer period of time. Do you have...
Could you say that last thing? Insulin?
Insulin raises mTOR for a longer period of time. Sorry, the bird's tweeting.
That's all right. Yeah, mTOR is an interesting one because overstimulation of mTOR can also interfere with insulin signaling and cause insulin resistance, right? So there's definitely a link between mTOR and insulin. And mTOR is very preserved, from yeast to, for all the basic unicellular organisms across life, you see mTOR preserved, but it's really in the multicellular organisms where insulin signaling and growth factor signaling is important in mTOR regulation as well. So it's in the multicellular organisms that you start seeing, insulin and insulin-like growth factor signaling playing a role with mTOR. I think in terms of proteins, obviously dosing the protein right is important. Overdoing the protein will set you up for gluconeogenesis because all these glucogenic amino acids will play a role in gluconeogenesis, right? And that may give you an insulin effect as well. So this is the part that I think people don't understand. And so that's the other thing about if you're doing intermittent fasting and you're having a huge dose of protein in that one meal, right? Well, no. First of all, I don't think we're having the same effect as if you are, kind of spreading out your protein dose, for example, right? So we do make sure that our patients keep within the 30 to 40 gram sort of range per meal. Okay? I tend to go on the higher side with my older patients, so closer to 40 grams, let's say. And maybe the younger ones, you can get away with 30 grams per meal, right? Most people will tell you, if you're doing the 40 grams of protein per meal, whole protein per meal, so, you know, like at 25 to 30 grams whole protein, that's going to get to about 2 to 2.5 grams of the leucine load. So we get that mTOR effect there. So, you know, if you're doing that amount of protein, it's very satiating. It's really hard to get people to eat beyond that, right? If you do it right and do it consistently. So I do respect the dosing per meal. I try not to go too high. If I want a little bit of insulin effect sometimes on patients without using carbs. So this is primarily, Susan, if someone's done a bout of resistance training, I want a little insulin effect there, you know, you could go with carbs, but I've tend to choose protein and give them a little bit of insulin effect that way, and help give a little bit of anabolism that way as well. So there are ways that there are strategies that you can utilize depending on the patient population. Yeah, so I do, but you know, if my patient population is eating that load of protein in the range of 4 to 5 times a day, right? So that's a really good dose for the day.
You're looking at 160 to 200 grams of protein a day.
In that range, yeah, depends on the patient and age and so forth.
And I just want to say to people who might not be clear about it, the amount, when you're talking about grams of protein, you're not saying that's how much the piece of meat should weigh. And I think people get confused with that, because people will often say to me, oh, I easily eat 30 grams of protein a day. But they're thinking that the actual piece of food weighs 30 grams. They're not looking at how much protein is in that food.
Yeah, so you're looking at the protein load, and then the food may weigh a certain amount, but it may contain fat, it may contain, you know, other things, water in it as well, right? So yeah, you have to go by really the content of protein, and you can look that up and do those calculations.
But I think in general for New Zealanders, you're looking at about 120 or 130 gram piece of food. So chicken or fish or, you know, some beef or something like that. So if it weighs roughly 120 to 130 grams, you're going to be getting about that 30 gram bolus of protein.
Yeah, I lost track of the metric system, so I'm taking your word for it. And also, I hate to cook, so I know that's one thing. My patients make fun of me because I hate to cook. I mean, I ingest, but I call myself the one finger cook, and it's waiter, takeout, and microwave, right? So, but I'm really not that bad, but I just don't enjoy cooking. I hate chopping.
It's certainly easy when you're very low carb and you tend to eat a lot of meat. That makes time in the kitchen much easier.
Yeah, that's true. It simplifies everything. You don't think too much.
Couple more questions.
Sure.
I've been keeping you for a while now.
It's been fun.
Talking about takeout, what about PUFAs? What about the seed oils? What are your recommendations there?
We really try to avoid the seed oils now. Yeah, absolutely. I always tell my patients, if you do a lot of takeout, if you eat out, you're eating PUFAs, the omega-6s, right? The unhealthy PUFAs. And the reason is that there is no restaurant, no matter how fancy, that will not be using those seed oils because it's a lot cheaper. And, you know, that's essentially what you'll be eating if you go out and eat in a restaurant or you order takeout. So, you know, people don't understand that. Sometimes they go, I don't use any seed oils. And then you find out that they are eating out quite a lot during the week. So yeah, we do have our patients really avoid the unhealthy seed oils. And it's hard to, you go ahead. Yeah.
Can you explain a little bit why they're unhealthy? What are they doing to people's health? Why should they avoid them?
Yeah, the PUFAs stand for polyunsaturated fatty acids, right? And we have, these chains of carbon within the fatty acids. And if you have unsaturated bonds, it means you have double bonds in there, which means that fatty acid is more reactive, right? And we have different types of these PUFAs. We have the omega-3s and the omega-6s and the omega-9s. And those numbers just tell you where those double bonds are. What we do know is that the enzymes that are used to process these fatty acids, they are the same ones for these PUFAs. And so there's competition when you actually eat the PUFAs as to which of the PUFAs are going to be kind of processed with those enzymes. We generally know that with the omega-6s, you tend to have more inflammatory profile with the omega-6 PUFAs than the omega-3s, for example. The omega-3s, I think everybody knows of as the ones they find in fish oil and so forth. Now, the omega-6s, however, they're everywhere because they come from a lot of the seed oils that are used in manufacturing, and then as a byproduct, they're sort of cleaned up and deodorized and then sold for culinary use, let's say. But they're also primarily used in processed foods. So when they're making different processed foods, your chips and that kind of stuff, they're using those seed oils. And the ratio, the optimal ratio between your omega-3s and omega-6s should be about 1:1, and that's never really the case. In the average American population, it's one of the omega-3s to about 25 the omega-6s, right? And when you figure that the half-life of these PUFAs is about 2.5 years, so if you have some peanuts and you want to try and get some of those omega-6s out of your body, it'll be about 7 years, right? That's a long time. And we get a lot of these that are incorporated into your brain as well. Your brain has a lot of fat, right? So these are things that people don't think about, especially in the keto crowd, because they're always, pushing nuts.
Yeah.
And most nuts have the omega-6s, right? And almond has 2,000 times omega-6 than omega-3s. There's no way you can write that ratio. And everybody's using almond flour and almond something something to make a keto something something. So we're rather boring because our patients are, well, I found this in a recipe book, and why can't we make this keto dish? And I was like, because of the almond, no almonds, and people are rather shocked. They're like, but aren't they good for you? But there's just no way you can write the ratio when you look at that. So we really don't push nuts at all. We don't recommend, nuts are not on our recommended list of foods. It's really very hard to get nuts that don't have the omega-6s. And I worry because a lot of, like I said, these keto dishes are made with almond flour or other nut flours or nut butters, that kind of stuff.
And now we have all these nut milks that are being made as well.
Yeah, absolutely. And I'm just like, that's not helpful. So that's never in the recommendations for our patients, right? So again, I think if you focus only on one aspect, so you're thinking, oh, keto, and you're just looking at the macronutrient there, but you're also not looking at the quality of the fats and also what comes in the foods that might be termed keto, right? Then you're missing a whole category. So it's amazing because I do speak to a lot of people who will say that they don't eat seed oils and they don't touch omega-6s and they're keto, and then they're chomping down on nuts in front of me. I go, oh, no, it's a big dose there. Not very popular when I point that out.
And I think too, with things like nuts, if we go back to how our ancestors ate, I mean, we didn't have nuts growing in New Zealand to eat. I mean, they're geographic kind of food, and they were seasonal. So, you know, now we're sending them around the world on airplanes, and everyone's
That's right.
them all the time.
Yeah, yeah. And they actually, you know, I mean, like nobody's gonna really eat the one handful or whatever. And the carb count actually adds up very quickly, right? So everybody that's assuring me that they're keto, I'm like, oh, you just not very popular when I say that. So
All right. So last question, or something else might come up, but anyway, getting close to the last questions. Keto and exercise, or carnivore and exercise. We have this idea that we must have carbs in our diet to be able to exercise properly. Now, I know you're a dancer and you do a lot of exercise. What's your personal experience, and what do you recommend for your clients?
So I don't do a whole lot of carbs. Although I used to check my ketones. I haven't in a long while. So traditionally, I haven't had really a lot of carbs, and I've continued with resistance training. You know, that's usually what I do in terms of my own exercise regimen. I have supplemented with creatine, and you know, I will make sure I have my protein right after exercise, but I haven't really used carbs for hypertrophy, right? And I feel that in general, I've been able to get good results with my patients without you know, adding a whole lot of carbs. If I feel that they have a little bit of anabolic resistance as they grow older, I might, as I said, up the protein dose.
Yeah.
So I use that. And the idea is that then you get a bit of an insulin boost.
Yeah.
Okay. So, you know, so we ran this program in the past. We called it the resistance, and it was just a little fun competition thing to get patients to, you know, we put them in groups and they got very competitive and so forth, which was good. So, you know, so as we were planning this, we had the meal plan as well, because we wanted to make sure that they were able to build muscle and so forth. So the first iteration of this, we thought about it. We was like, okay, this was a while ago. We said, okay, we'll give them a little bit of carbs to give them a little bit of an insulin effect. So after long discussion, you know, Anna, who's the head coach, she says, okay, we'll give them one green apple. How's that? I was like, okay, one green apple. Well, you know, that didn't go so well because, you know, everybody's definition of one green apple is very different, right? You know, we learned that. We're like, ooh, okay, that's an interesting, oh, I see. So in your household, yeah, one green apple is quite something different, right? So then we stopped that, and I was like, okay, nix that idea. So the next time we ran the resistance, I said, no, we're going to do this with protein. And what we did was, then we just gave them a higher protein boost in the meal following the exercise, right? And so since then, we've used that strategy, and that has been more successful and less straying off the path, shall we say. So, you know, I learned from my patients as well. So I will do a higher protein kind of meal.
Would you use something like, you know, what are your thoughts around a whey protein after a workout?
Yeah, because that will give you a nice quick insulin boost, whey specifically, right? So you can use the whey protein, and we've done that. I've done that. We've tried everything on ourselves and then measured our sugar levels and our ketones and everything. And you see with the whey, it comes up nicely. So yeah, I will sometimes use whey. Overnight, I use casein for the patients because overnight I need a longer effect, and the whey effect is too fast, right? And what I want is to cover as much of that catabolic window as possible. So in the older patients overnight, I use casein.
Right. Okay. And what about just amino acids? You know, there's lots of companies out there now putting out different
Yeah.
amino acid formulas for, you know, some for workouts, some for liver function, you know, some for just general health. What are your thoughts about using those?
Certainly, sometimes I've used essential, amino acids for a little boost, for some of the patients. So it really depends on the patient population. If they're younger, I don't necessarily go to it as much, but in the older patients where I'm really, having trouble getting their muscle mass up, or they're already sarcopenic, yeah, I may use the amino acids. And, with mTOR, you need the leucine, right?
Yes.
But you also need the arginine. And, so sometimes, a lot of times people just give the branch chain. I like to give just the, like a whole, yeah. So that's a little bit easier. But I'm also careful, then there are people who will use amino acids and dose them on their own. So another famous thing, I'll probably talk about this on an episode, this whole nitric oxide thing.
Yes. Yeah.
Right. And I'll have patients try to boost their own nitric oxide, and then they'll dose with arginine. And I don't think that's a good idea, simply because we've seen that with increased arginine, that it's correlated to increase in liver cancer. So dosing these amino acids, I'm very, very careful. I try not to go overboard with them. And like you said, Susan, I much prefer to use food. Maybe a very specific population and very specific circumstances, I will use some supplementation, but food is always best.
And I think, that comes back to the same thing with our vitamins and minerals, is how these amino acids are combined in food, how our vitamins and minerals are combined in the food we eat, is what our body recognizes and needs, and they're in the right ratios with each other.
That's right.
And I think that is, that's so important. And we go down this, something pops up on the internet and everyone goes down this little tunnel of, okay, I'm going to boost my nitric oxide because it's good for me, without really looking at the implications of the big picture.
Yes. And then, the focus becomes just that one thing, right? But like I said, it tends to be in the body, these domino effects, that you don't even anticipate or realize, because all these pathways are connected. They don't exist in isolation. So, you push something over here and there are three things going on over there that you didn't even look at, right? Because the study only looked at this one piece.
Yeah.
So.
And when when you look at the, a pathway map with all the pathways, and I mean, we've got billions of chemical reactions going on in our body every freaking second that we're not even aware of,
That's right. I mean, and that they're all actually happening at the same time, right? But in different proportions. So, people always think, oh, you need to cut your carbs to a certain level and then you'll have ketogenesis. Well, you make ketones all the time. It's just such small amounts that it's not measurable and not noticeable. But it's not like, now you have it, now you don't. And it's not quite like that, right? And, we think of, oh, if you don't eat carbs, you don't have insulin. You always have some insulin. And it's just a gradated response, right? And it's going to be based on nutrient sensing, and your body is brilliantly made for nutrient sensing and energy sensing, and we adjust accordingly. So these processes are happening all the time in different tissue, in different amounts, right? And it's that overall net balance.
And I think, I feel now that the focus has finally come to insulin, which I think is a really good thing, that now everyone's talking about insulin, but then it gets misrepresented as it's really bad and we don't want insulin. And,
Totally.
We need it from, so, I mean, we need insulin. anabolic.
Absolutely. So that's, exactly why, I mean, I've taken my time to get to the topic of insulin resistance in the podcast. So I started, the episode that just came out was on carbs, and then I'll be talking about low blood sugar and high blood sugar, and then I'll finally wind my way to insulin. But you're exactly right that we can't look at something in isolation and just, it's good, it's bad. And in general, it's in your body because you need it, right? That's number one. And when we talk about insulin in general, we've only focused on the glucose disposal aspect of insulin, right? And sure, that's very important, but that's not the only thing insulin does. It has really profound influence over behavior, over feeding behaviors, for example, right? And it, in muscle growth, in proliferation, in cell survival, in vasculature health. So insulin has profound effects throughout the whole body. But when we have these conversations, we've only focused on the glucose disposal aspect, right? And then in very kind of black or white scenarios. And that's where we need to understand that it's a lot more nuanced than that.
Well, this has been fabulous. I have loved talking to you.
Here.
I'm really looking forward to talking to you and meeting you. And I really encourage everybody listening to this to go out and find Vyvyane's work and her podcast. Could you tell us where they can find it? And we'll make sure we put everything in the show notes for you.
Oh, thank you. So the podcast is called VLMD Rounds. So VLMD, my initials, and then rounds as in medical rounds. And that's on YouTube. If you search for that channel, it should be there. But it's on the different like Apple Podcasts and so forth. So you can find it if you just want the audio as well on podcasts. And then my website is vyvyanelohmd.com. And I'll be doing a series of Q&As, live Q&As too. I'm going to be trying to vary some of the times because it seems I have some listeners from New Zealand, from Australia. So I'm hoping to make it such that people can attend because I love interacting with the audience, and I love answering questions, and I love also seeing what people are interested in, because my main aim in doing the podcast, Susan, is to make people realize there is so much we can do to optimize our own health, right? And unfortunately, that discussion doesn't go on in medical school. It doesn't go on in the general medical world. I learned that myself. And I then had to put myself through my own curriculum of learning how to take care of myself and then extending that to my patients. But I really feel that when we do medical education, a lot of it is dumbed down and quite insulting, actually. I listened to some of this and I'm like, where'd you get that from? Because Self Magazine did a better job than you. These handouts that we give people. And I just think that when you really give meaningful education to people, they take that information and they run with it, and they start to look at their own health and their family's health in a different light. So that's really what I'm hoping to promote, is to get people to realize how much control you have, no matter where you are on your health journey, no matter where you are. I mean, I keep talking about reversing disease because we never talk about that.
And it's
right?
doable, and we need to be talking about it.
Yes, and most chronic diseases are reversible, right? And I have taken people with kidney disease, stage 3, stage 4. I have one person on a transplant list that got off the transplant list, one person. So people with diabetes, okay? People with high blood pressure who no longer have high blood pressure, don't take medications and so forth. So most of these chronic diseases are a lot of the autoimmune diseases. I see a lot of inflammatory bowel, for example. Okay, so those, I tend to have a lot of, I have a lot of doctors who send me their kids with inflammatory bowel. So I see a good amount of those with inflammatory bowel disease, and those also actually have really, really good prognosis if we teach them how to take care of themselves. So I just think that we're not having this conversation with patients, where the conversation is around, well, you have it, it's genetic. No, it's not. It's epigenetic. And also, oh, once you have it, you'll always have it. And that's not true.
Mm. And the solution often to me seems to be, from what I hear from my clients, is, oh, well, you just lose some weight. And I think that we've really focused the wrong way around, where we're really focusing, everyone's focused on losing weight. How can I lose weight? How can I do it as quickly as possible? And then I can go back to once I've lost it, I can go back to what I was doing. And what we really need to focus on is health first. Once we get healthy, then our weight will stabilize maybe to the weight that we're supposed to be. And maybe not everybody will feel altogether happy with that, but at least having good health.
Oh yeah, I mean, I have patients and I've had to calm them down and get them, because I know it's really hard. They come to me and they want weight loss and they want to see a number on the scale, and it's been 3 months and they lost 3 pounds. And what did I do? I added another meal, and they're going crazy. I'm like, you just got to trust me on this. And then you dex them. No visceral fat, increased muscle mass. Their clothes fit better. They've never felt better. They look and feel very different, and they go, oh my God, who would have thought it's possible? And I'm like, you have to remove this idea of, I have to lose X amount of weight. We have to get you to a place where metabolically you're healthy. And that might mean different things for different people, right? So having that kind of conversation with the patient, but it's really hard because the doctor is yelling at them to lose weight, right? Everybody's blaming the weight. There's all this pressure in society to look a certain way or to weigh a certain amount. And you could be doing more harm by losing weight. You could be doing a lot more harm by losing weight.
And I know, getting older myself, my focus now is on being as fit and strong as I can be going into the next 20 years or so that I can still do the things I love. So I can still paddle my kayak and ride my bike and tramp the mountains and walk my dogs and play with my grandkids.
Absolutely. And that's the norm, Susan. That is the norm. And we just turned it around where we think that that is not possible, but that really is the norm. We were made to function well. We were made to go out the kadunk way, right? La 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 kadunk. That's right. I mean, that's how I think we should all go.
Yeah,
right?
yeah. Rather than going out with chronic disease, I like that.
Yeah, yeah. I don't like the no. Oh, I was just like, tra la la kadunk, done.
Oh, that's brilliant. Oh, that's probably a perfect note to end this. We've been talking for an hour and a half, so it's gone so quickly. Thank you so much. It's absolutely wonderful to meet you. I'm a huge admirer of your work.
Oh, thank you. Thank you. I've had a lot of fun.
Thanks for coming on today.
Okay, I hope we do this again sometime.
Yeah, me too.